Thanks, Serge and Appy and Will and everybody else who's responsible for putting together this program, which has been just fabulous so far this morning. It's wonderful to see my old friend and colleague, Yuri Ladabaum, who actually did his fellowship with us at Michigan many years ago. And I am going to talk about the future of GI, but I'm going to focus my comments more in disorders of gut-brain interaction and specifically irritable bowel syndrome, which I think serves as a jump point, a nice jump point, to help us to understand where a lot of our practice is going. Again, from this morning, we've heard about so many exciting things that are happening in gastroenterology, whether you're talking about the use of artificial intelligence and machine learning and endoscopy to genetic testing. You think about how our field is going to change in the coming years, and really almost unrecognizable compared to the field of gastroenterology that I learned about, over 30 years ago. So we're going to focus our comments on the irritable bowel syndrome, which of course is an incredibly common problem. In fact, it's the most common diagnosis rendered by all of you in the audience, and it's a symptom-based condition that's really predicated upon the presence of abdominal pain and altered bowel habits. And this is where we are still in 2022, is we define the most common diagnosis we give in clinical practice by the presence of characteristic symptoms. We do some diagnostic tests, but the tests are all to exclude other diseases that can mimic IBS, not to confirm the diagnosis of IBS, if you will. The clinical phenotype is really diverse. So there are patients with harder lumpy stools, so IBS with constipation. There are patients with looser watery stools, so IBS with diarrhea. And of course, this most confusing group in the middle, right? The ones that have both constipation and diarrhea. And what this really tells you is that this isn't one disease. This is really a bunch of different diseases for which we don't currently have the biomarkers to be able to parse patients on the basis of pathophysiology. So we define by the presence of characteristic symptoms. This is not to criticize the Rome criteria, but only to say that in its current form, it's not very sophisticated, and it really reflects the heterogeneity that is inherent to this kind of diagnosis is reflected by a whole wide range of things, not the least of which are issues around the likelihood of a specific treatment to make a patient better. And we'll talk about that more in a moment. So the most recent pathophysiology around IBS is starting to more and more emphasize the importance of the luminal microenvironment. So what's happening within the lumen of the gastrointestinal tract, which of course harbors the food that we eat, the microbiota, the organisms that live within the lumen of the GI tract, and then endogenous factors like bile acids, proteases, and the like. Now, those luminal contents interact with the enteric nervous system as well as the gut immune system via the intestinal epithelium. And that intestinal permeability, which lay people tend to call leaky gut, plays a really critical role on what the enteric nervous system and gut immune system gets exposed to that's residing within that luminal microenvironment. And of course, once there's activation of the enteric nervous system and the gut immune system, there's a whole host of things that happen both locally and systemically, including in the brain. So for years and years and years, we've talked about brain-gut interactions, but increasingly we're now talking about gut-brain interactions. And it's not to diminish the importance of one or the other. This is not, it's not a dichotomous kind of thing. It's very much a bidirectional relationship that we're just now starting to better understand. So where are we right now in regards to treating irritable bowel syndrome? Well, we have medications. We'll talk about that very briefly in just a moment. There are diet therapies, which are rapidly emerging and continuing to evolve. The low-FODMAP diet should be viewed as a beginning, but by no means as the end. There's going to be a lot more regarding diet and IBS. And then finally, behavioral therapies. Again, pretty much at the beginning of the journey, although I think anybody you talk to that's going through a GI fellowship at this point would believe that behavioral therapies are a really valuable tool in treating patients with DGBI and other GI disorders, whereas that wasn't even on the radar screen when I was going through fellowship 30 years ago. So pharmacological therapies, there are a lot of different quote unquote evidence-based therapies for patients with IBS. And these drugs that are evidence-based are clearly superior to placebo. They, the one thing to keep in mind about that statement is that medications that are beneficial for IBS generally make somewhere between 40 to 60% of the patients better. So around half of the patients get better, which means, of course, half of the patients don't get better, and offer a therapeutic gain in the range of 7 to 15% over placebo. Now, that's highly statistically significant in a phase 3 program that includes thousands of patients, but it by no means provides a silver bullet for the patients that you're seeing in practice. So in other words, some of the patients get better, some of the patients don't get better. And again, this is a reflection of the heterogeneity of the condition as it's currently defined. If you think about it, if you develop a drug for serotonin or opioid receptors or GCC receptors, and the pathophysiology of the disease in that particular in your particular patient doesn't involve those processes, the drug is unlikely to make the patient better. So we're doing a lot better in terms of drugs. We have a lot more options. But again, given the inherent issues around the way we define the disease or disorder, we're never going to do better than around 40 to 60% until we parse by pathophysiology. Now, this is a valuable document. It's worth a quick read if you haven't seen it. It's the AGA Clinical Practice Update on Diet Therapies for Irritable Bowel Syndrome. And I use this slide just to introduce as we move into the discussion of diet. There's a lot of valuable, very practical information in this clinical practice update. And remember that CPUs are different than guidelines, and that guidelines really focus on the evidence. CPUs focus as much on expert opinion as they do on the evidence. In this particular diet CPU, we have this algorithm, and it really comes down to this, that one of the very first things you should do when you're discussing symptoms in a patient with IBS is to understand their triggers. Okay, so the most common triggers are stress or anxiety, but even more common than that, much more common than that, is food. Okay, and the reason it's important is because if a patient tells you that their illness experience is triggered or worsened by eating a meal, diet therapy should really be top of mind as an initial intervention strategy. The other thing that should trigger and make you think about is whether there's disordered eating or an eating disorder. Okay, and we'll talk about that more in just a moment, in fact, right now. One of the things that I think that we as a GI community tend not to focus on or think about or screen for are the possibility of disordered eating and eating disorders. I think we're all very familiar with the legacy eating disorders, anorexia and bulimia, but you may be less familiar with these other conditions. So the first one is orthorexia, and here in California, it may be that you're more familiar than we are with this in Michigan. But this is an obsession with eating foods that one considers healthy. So people will focus and eat only foods that they perceive as healthy. And then there's the flip side, the exact opposite of that, called avoidant restrictive food intake disorder, or ARFID. You're going to start to hear this term thrown around at a lot of GI meetings. It's really picking up steam. But it's a condition where people are hyper picky eaters, almost as if they have food PTSD. So related to having negative experiences related to eating food, these patients begin to malignantly avoid a growing list of foods to the point that they develop malnutrition, require feeding tubes or nutritional supplements, or even sometimes end up on TPN. So to qualify for ARFID, it's not just being a picky eater. It really is being a picky eater to the point where you're restricting so much that it's having adverse health consequences. But we all see patients like this in our everyday practices. And, I think that I dare say that most of the time we know there's something wrong, but we may not have known that there's actually an actual diagnosis that is ARFID. And this is a condition that needs to be addressed as an eating disorder by eating disorder specialists. For example, this is not somebody that is going to be primarily treated by a GI psychologist, for example. These are patients that really need to be sent to an eating disorder specialist. So where are we at the current time in regards to diet therapies for IBS? Well, this is a list that's from that AGA CPU that was just published. And there are diets that are at least somewhat evidence-based. So the best example of that would be the Low-FODMAP diet, but also practical common sense dietary recommendations as offered by the British Dietetic Association in the UK's NICE guidelines are also beneficial, probably in 30 to 40% of patients. Not bad. We'll go through those recommendations in a second, but just the common sense recommendations that you can make, and you'll make many of these already, but if you sort of organize these maybe into a document, maybe a third of the patients get better with these common sense recommendations. And increased soluble fiber, of course, for patients, particularly with constipation. There are a whole bunch of other diets to consider. So, for example, there's a lot of interest right now about using a balanced or Mediterranean diet in patients with IBS, not fully evidence-based yet. And I don't have time to talk about that during, I think, this talk, but we can certainly talk about that during the QA. And then there are biomarker-based tests like confocal laser endomicroscopy-based elimination diets or leukocyte activation test-based elimination diets. And then finally, a gluten-free diet. There is some data, and actually there is a growing body of evidence to suggest that a gluten-free diet may be a very reasonable approach in some patients with IBS. And then there's a whole bunch of other things at the bottom of the list for which we really don't have a lot of data at the current time. So here are those practical recommendations. And so eating regular meals and taking enough time to eat, avoiding missing meals or leaving long gaps between eating, drinking enough fluid, restricting the consumption of tea and coffee to a small number of cups per day, reducing intake of carbonated beverages and sugary soft drinks, reducing the intake of resistant starch, limiting the amount of fresh fruits to 3 portions per day. And of course, this sort of dovetails with the whole FODMAP approach because 3 portions of one type of fruit may not be the same as 3 portions of another type of fruit. Also, people with diarrhea should avoid sugar alcohols. And this seems like such an obvious common sense thing, but it strikes me that I still see patients in clinic oftentimes with diarrhea where nobody's really asked them about candies that they're eating or diet-based foods that they might be consuming that could contain sugar alcohols. And then also something we don't use a whole lot, but they really like in the UK is linseeds or flaxseed. So that another fiber source that can be valuable and tends to not cause as much gas and bloating. So as I mentioned a moment ago, the most evidence-based diet at the current time is the Low-FODMAP diet in terms of improving global symptoms. This network meta-analysis actually suggests that the Low-FODMAP diet provides the greatest degree of benefit compared to other diet strategies that have been evaluated in patients with IBS. That's also true for pain and bloating. And at its heart, actually, most people don't realize that the Low-FODMAP diet is really a strategy that is most likely to improve pain and bloating. It can also improve diarrhea, but not as reliably. If you use the Low-FODMAP diet, remember that you want to make sure that you recommend all 3 phases of the diet plan. So elimination or restriction for a period of 2 to 6 weeks. If a patient responds, you'd go on to reintroduction. So you reintroduce foods that contain individual FODMAPs to determine a patient's sensitivities, and then In the third phase, you personalize a diet based on the information you gained from that reintroduction phase. A really important thing is in that blue box, and that is if the patient has not enjoyed any benefit to their symptoms after 2 to 6 weeks, you abandon this diet and move on to some other therapy. Do not leave people on the low FODMAP diet. Now, some recent research gives us insight into the FODMAPs that most commonly trigger patients' IBS symptoms. Like you might ask yourself, you know, there's 5 different categories of FODMAPs. Which are the ones that are more likely than others to cause problems? And it turns out that in a study by our group and a study by Jan Tak's group in Belgium, we both independently found that fructans are by far the most common culprit FODMAP. Why is that important? Well, remember that the most common source of fructans are things like garlic and onions, which are in almost everything that we eat. So that's an important thing to realize. But fructans are the primary carbohydrate in wheat. Okay, so for all these patients that you're seeing in the office that say that they're gluten sensitive, some of them are gluten sensitive, but many of them are actually sensitive to the fructans in the wheat that they're consuming. The other thing that's really interesting about this observation is it opens the door to developing a different way of approaching the low FODMAP diet. So think about this. Right now, we have a top-down approach. In other words, we exclude all of the FODMAP categories. We see if a patient gets better, and then we reintroduce foods to determine a patient's sensitivities. There are other groups that are experimenting with more of a bottom-down kind of approach. In other words, excluding fructans and galacto-oligosaccharides, for example, seeing if the patient gets better, and then only excluding other groups of FODMAPs if the patient doesn't get better with that less restrictive version of the low FODMAP diet. So there's no right or wrong answer here. I put this out here because, you know, for creative people, there may be less restrictive ways by which to administer the low FODMAP diet, which may be just as effective. So again, we're very much at the beginning of this journey. I think that we're going to continue to see a lot of innovation in this space with the low FODMAP diet, but also other diets as well. So there is long-term data, a nice study from the United Kingdom that followed over 200 patients from 6 UK centers who took IBS patients and had them undergo a dietitian-led low FODMAP diet and then followed them for 44 months, a mean of 44 months. You know, bottom line is that the patients continued to do well on the low FODMAP diet. So the statement that, oh, patients can't do this and it doesn't continue to work is actually not true. In this large observational study, patients were able to continue to do it, and they did continue to respond. The other thing, the other myth that's out there is people will say, oh, well, people can't reintroduce and they don't liberalize their diet. They stay on the full restriction for the whole time. This study, over 80% of the patients actually were able to liberalize their diet through reintroduction. So I think it's an important study just because it blows up a lot of the sort of negative myths around the use of the diet. If you utilize all 3 phases, patients can absolutely do that, particularly if it's with the aid of a dietitian. And it continues to work, and they can continue to adhere even for years. All right. So there are a number of biomarker-based approaches which are being developed because right now, the low FODMAP diet makes around 50 to 60% of the patients better. Does that sound familiar? That's exactly what I told you about the medications. So it's not as if the diet therapies are, again, a magic bullet for patients with IBS. They're just another option that work about as well as all the other options. And again, it just underscores that theme of heterogeneity that I spoke to you about that's inherent to patients with IBS under the current diagnostic construct. We'll get back to that biomarker-based approach at the very end, because I think it's what's happening in the diet space is a great example of what should happen in many areas of gastroenterology. And in fact, a lot of these themes that I'm talking about, I'll try to point out to you, are really themes that can be applied to a wide range of different disorders, not just IBS. So psychological therapies or behavioral therapies, again, I think have widely been or have been increasingly embraced in conditions like IBS, but also other conditions like inflammatory bowel disease, for example. It's talked about more and more in the setting of IBD. But we used to say that psychological or behavioral therapies should really be reserved for patients with severe symptoms who don't respond to anything else. That has completely flipped on its head over the last 5 years. So we now say, no, it's any patient at any part of their journey, as long as they understand that stress or anxiety is related to their symptoms and they're willing to engage with a therapist. Okay, so those two key factors, is there stress or anxiety? Might it be related to their symptoms? And then the last thing, are they willing to engage with a therapist? Are huge predictors of success of behavioral therapies. This is data from the latest network meta-analysis, still online early at Gut, but summarizing data from 41 studies, 41 randomized controlled trials evaluating different behavioral therapies for patients with IBS, an incredible body of literature. I think really decisively showing benefits of behavioral therapies for patients with IBS, in particularly related to cognitive behavioral therapy and gut-directed hypnosis. This is a slide that I stole from Sarah Kinzinger, a well-known behavioral therapist in Chicago, who points out that the number needed to treat yielded by the studies, the randomized controlled trials, which have evaluated cognitive behavioral therapy for patients with IBS, yield at least comparable, maybe even a little bit better, NNTs compared to the FDA-approved medications that are available for IBS. Now, does this mean that behavioral therapies are better than the medications? Absolutely not. That's not the point that I'm trying to make. But I am trying to make this point, which is they're probably at least as good. These are not studies you can directly compare. It actually would be very interesting network meta-analysis to look at different treatment options across the disciplines, like diet therapies, behavioral therapies, medical therapies. That'd be very interesting. Now, I think for time, I'll skip over that one. I'll go to this one. So this is actually data from Jeff Lackner's group at the University of Buffalo, data from a multi-center NIH-funded randomized controlled trial evaluating minimal contact cognitive behavioral therapy versus traditional cognitive behavioral therapy versus education alone in patients with IBS. You might ask yourself, why am I showing this trial except to reinforce what I've already said, which is that CBT does better than, for example, education alone in patients with IBS. But this is a really important study. And the reason it's really important is because the minimal contact group had one face-to-face visit, and then the duration of their cognitive behavioral therapy intervention using a web-based platform, so all online. And it really was the first study to show that a digital application of cognitive behavioral therapy did just as well as having to come in to see a therapist face-to-face. So this opened the door to the possibility of developing digital therapeutics, which I'll talk about in just a moment. This is one of the big mega trends that's going on in gastroenterology at the current time. So where are we going? In the second half of this talk, I'm going to focus on integrated care, digital health, and biomarker-based treatment selection strategies. So Helio just recently actually did a full front page spread on integrated care. And integrated care embraces this concept that we should move beyond an approach where we try to choose only the right medication for the right patient, and really embrace the evidence that I've just reviewed for you on diet therapies and behavioral therapies, at least as it pertains to irritable bowel syndrome. And I would also say that not reviewed so far, but coming to a practice near all of us soon, I think, are CAM therapies. I think that some of the most innovative, interesting work going on right now in DGBI and GI in general, actually, relate to things like electrical stimulation and or alternative therapies like abdominal massage, or even data that was just presented at Digestive Diseases Week on a vibrating capsule for constipation. I mean, think about, these are like crazy ideas, right? But there are several investigators across the United States right now that are looking at electrical stimulation, either acupuncture-based or just transcutaneous, for things like abdominal pain, constipation, diarrhea, IBS. And then things like mechanical stimulation, either transcutaneous or like capsule-based stimulation of the GI tract to alter physiology in a way that's beneficial for certain conditions like constipation. We're going to be throwing around a bunch of terms. I think that this is more for just your education. Integrated care is a general term that applies to the use of behavioral therapies to any condition. And I also use this term to apply to behavioral and diet therapies, for example, to IBS. Integrative medicine, as defined by the global health advances in health and medicine, is a care approach that puts the patient at the center and addresses the full range of physical, emotional, mental, social, spiritual, and environmental influences that affect the person's health. So it really sort of is a more holistic approach to treating the patient's symptoms. And then precision medicine and precision health really are talking about strategies that utilize biomarkers to parse patients on the basis of pathophysiology to choose the right treatment for the right patient, as opposed to the way we do things right now, which is you have this symptom, we have this suite of strategies, let's keep trying things until we find something that works. Okay, that's the opposite of precision medicine, precision health. So if you think about the evolution of the IBS care model, for many decades, we were at traditional care where the gastroenterologist saw the patient and largely identified predominant symptoms, diagnosed the disease, and then chose a medication based on that. We've moved towards multidisciplinary care, and that's where we are mostly in the United States right now, which is, I think most practices really have accepted the fact that diet therapies and behavioral therapies are valuable assets to treating patients with IBS, for example. But that's different than integrated care. Integrated care is where there is a collaborative group discussion between the providers to develop a personalized care plan that includes those multidisciplinary assets, diet, behavioral therapy, and medical therapy, for example. And I think that a really important way to think about this is these are not siloed, sort of separate things that we're doing for these patients. They really should be, it really should be an integrated plan. That is sort of the pie in the sky, the aspirational goal, although I know there's lots of operational barriers to get around.
In addition,
so this is that idea about integrative care, the idea that there's a healthcare team really led and captained by the gastroenterologist when a gastroenterologist is involved in the care of a patient with IBS, for example. But that includes these other partners, which in some cases, the other partners will be as important or more important than the gastroenterologist. Integrated care is a better way to care for patients with IBS and other DGBI. This is a study that was published in Lancet Gastroenterology and Hepatology about a year ago now, almost 2 years ago now. It's an important study because it's a pragmatic clinical trial looking at integrated care versus usual GI-based care in 188 patients with FGIDS. And the integrated care group included collaborative care, which including care from a gastroenterologist, a registered dietitian, behavioral therapist, and physical therapist actually as well. And you can see that usual care actually did really well, 57%. Almost 60% of IBS patients got better with just gastroenterology-based usual care. But look at the integrated care group, 84% reported significant improvement of their overall GI symptoms at 12 weeks. That's pretty darn good. And they just published their long-term data, which is 2-year follow-up. And integrated care continued to provide statistically significant benefits compared to traditional GI care at 2 years follow-up. But there are problems. Okay, it sounds fantastic. I think everybody in the room would probably accept that this makes a lot of sense, but operationally, this is not so simple. So there is limited evidence. In fact, in addition to that one study that I showed you, there's almost nothing else to really prove the benefits of integrated care. So it's very much in its infancy, although intuitively, I think we'd all agree that it makes a lot of sense. There is a lot of data that is being generated and other studies which are being done to prove the benefits. So I think in terms of solutions, there's definitely limited access to dietitians and GI psychologists in the United States. For example, there are fewer than 100 GI psychologists in the entire United States right now. So it's wonderful to talk about behavioral therapies. Unfortunately, for most of you in clinical practice, you're not going to have access to these services. Just to give you an example, we have 3 GI psychologists just at University of Michigan. So 3 out of the 100 are at our center. You know, so it's very much at the beginning, but in the next phase of this talk, I'll talk to you about how we can scale solutions that could provide benefits to everybody, as opposed to just people in ivory towers like Stanford or University of Michigan or Kaiser. I know Kaiser is thinking about you know, adding some of these services as well. I was just speaking with them about this. There are high upfront costs and logistical barriers to, let's see if we can go back there. Can you go back one slide for me, please? To developing integrated care. You know, the reality is, like, for example, at our place, when I first introduced this idea of developing this program, I got a lot of pushback from the administration because they were like, so let me get this straight. You're telling me that you want to take rooms from doctors and give them to dietitians who are going to generate, you know, little to no margin, or GI psychologists that again are not going to be profit centers. By the way, you don't lose money on these things, but you're not going to generate, you know, a tremendous amount of revenue, as much revenue as you would with a physician appointment. But again, there are ways to get around this. So in other words, I think that the way to get around this, as I'll talk about in just a moment, is to not have them take up an office. So for example, let me give you an example at our place. Now, all the nutrition services, 7 dietitians and 3 behavioral psychologists, none of them are in the clinic anymore. They all do 100% virtual. So they take up no space, actually. And, you know, you can imagine that the business model is really different when they're working from home. So multidisciplinary integrative care models improve clinical outcomes. They may reduce costs. That study, the mantra study that I showed you a moment ago, also suggested or found that there was reduced cost per cure with integrated care compared to traditional care, which is interesting, right? So you actually save money by doing the right thing. And it also redistributes responsibilities in ways that benefit patients and providers. This is a really important point. When you have this integrated team, you get far fewer calls on the physician side, because the dietitians and the psychologists are helping you to field those questions and to sort of take care of diet and, you know, emotional issues. So could you go back to that last slide for a minute? Sorry, I must have a timer on here. So integrative care does help us to get better in terms of the way we're treating these patients. But there are issues around utilization of these services and scaling them so that they're broadly available. Because right now, I think one of the problems is that these services are limited to a small number of centers, and they're limited to a small number of patients that have the resources to be able to pay for these things, which is really, I'm sure, not the intention of anybody in this audience. It's something that actually keeps me awake at night. I worry about this because it's really only a specific segment of the population that can enjoy the benefits of this particular treatment approach. So how can we operationalize all of these new treatment options for patients with IBS? Well, I think that digital health provides a way in which to bring this idea of integrated care forward. In fact, there's this incredible revolution that's happening right now. I think most doctors aren't aware of what is happening in the digital health space at the current moment.
In addition,
so this gives you an idea about
study randomized patients
the number
with a
of deals
variety
and the
GI
amount of money that's being invested
that roughly
in
60%
digital
of
health at
patients
the current
had
time.
IBS, and
You
in
can
that
see that it's
IBS
more
group,
than linear in
again,
terms of the
integrated
increase. In
care
fact,
did-
right now,
in addition,
there is about
this
$1
study
billion
randomized
a week
patients with a
that's going
variety of different
into
GI conditions, but
digital health
realized that
revolution. It's a
roughly 60%
staggering
of the
amount of
patients
money.
had IBS, and in that
And
IBS
so
group,
there's a lot of
again,
smart
integrated care
people with
did
a lot of
better
money that
than,
are placing their
standard
bets
care.
right now, and
In addition,
they're
the
thinking
cost
this
per
through and
successful
deciding
outcome was
that
higher
digital health
in the
provides a
standard
means by
care
which
than
to
in the
scale a lot
multidisciplinary
of these
integrated care
various
group.
types of
And quality of
services that
life,
I've been
as
talking about
measured by
now and that I'll talk to you about in
EQ5D,
just a moment.
improved.
So what are the options in terms of digital health? Well, there are mobile apps, and all of us are starting to use these mobile apps in our own practices, right? For example, there are diet, there are symptom trackers, there are bowel movement trackers and by the way, I think within the next few years, this is going to become a very commonplace thing for all of us to be utilizing with our patients in clinical practice. I mean, why not objectively follow stool consistency? Rather than having people try to remember the Bristol stool form scale, why not just click a picture every day and have it analyzed for you and have it printed out and recorded and reported for you in a quantitative way? By the way, there was a study at DDW this year showing that using a bowel movement tracker, there was a tremendous amount of variability between what the patient reported on a diary and what was actually found through image capture and objective measurement in terms of using the Bristol stool form scale. Digital therapeutics, so delivering evidence-based treatments like cognitive behavioral therapy or gut-directed hypnosis. That can all be done through a digital platform, either a web-based platform or a mobile app nowadays. At-home diagnostics, we've already heard about this with genetics this morning, but that's really just the tip of the iceberg. You know, the things that right now aren't widely available, whether you're talking about stool-based testing, which is going to become increasingly common, or saliva-based testing, which was discussed already in terms of genetics. Certainly anything protein-based or gene-based, you'll be able to do through saliva-based testing. And things like at-home breath tests are going to become very, very commonplace. And then finally, virtual integrated care platforms. And this is potentially the most disruptive and most threatening to physicians in big ivory towers like Michigan or in the community, because realize there are companies that are developing full stack integrated care platforms. So gastroenterologists, dietitians, behavioral therapists, physical therapists, CAM providers that will make this directly available to healthcare plans and also to patients. So it's an incredibly interesting time. There's a lot going on right now. And it's very likely that that the way we practice, the way we think about practicing, and the things that we can bring to bear for our patients are going to change quite dramatically. So here are some examples of some of the things that are some of the companies that are disrupting care in patients with IBS. So, for example, Dieta is a small company in San Diego that has developed an app-based symptom tracker, meal image analysis, stool tracker, and then uses AI analytics to sort of learn over time, you know, in terms of pattern recognition and understanding how symptoms relate to physiology. There are also symptom trackers, like, for example, My GI Health, which Brendan Spiegel and I invented, which actually uses the PROMIS questionnaires to collect data regarding various GI symptoms and then integrates that information and writes a history for you. So, you know, the patient imputes their symptoms, and then the system spits out a medical grade history of present illness that you can share with the physician. There are also digital therapeutics. Believe it or not, Mahana IBS is an FDA approved prescription digital CBT application. So Regulora is an FDA-approved gut-directed hypnosis intervention for patients with IBS. Nerva is not FDA approved, but has been developed by collaborators at Monash University. Again, is an excellent gut-directed hypnosis mobile application. And then Monash University has also, of course, developed the Low-FODMAP diet or mobile app. But you can see this is, and by the way, literally every month there's a new one coming online. Like this is, I put this together, a few weeks ago. And even since then, there have been other new ones that have come online. So this space is really rapidly evolving. And then as it pertains to these virtual integrated care platforms, Oshi Health is probably the one that's farthest along right now. This is an integrated care platform that will offer a full clinic to patients with IBS. So gastroenterologists, dietitians, psychologists. The platform will allow doctors to prescribe medications and 24/7 support. GI on demand, as already been mentioned this morning, GI on demand is taking a slightly different approach. Rather than trying to provide the full suite of services, the approach that GI on demand is taking is to try to understand where gastroenterologists need help. So rather than providing the full stack of clinical services, we're providing education around diet therapies, behavioral therapies. We're curating and making available on the website the best-in-class mobile applications for things like CBT, gut-directed hypnosis. There's the relationship with Ambry in regards to clinical genetics or around GI diseases. So and the platform is very much continuing to evolve over time. So I think this is the last part of my talk, but that where we want to go in regards to the way we think about and approach patients with DGBI in particular, and in this specific example, IBS. So I think where we want to go is precision health, right? What we want to do is start to identify biomarkers which don't just exclude other diseases which can mimic IBS, but help us to understand what type of IBS a specific patient has. Okay, those are very different things. So, for example, can we leverage the gut microbiome? Are there features of the microbiome which can help us understand who are or are not likely to respond to different types of therapies, like diet, for example? How about the metabolome? So maybe not focusing on the bugs as much as what the bugs are doing and whether or not that is predictive. I'm going to tell you about some devices. So, for example, we've invented a device, an office-based device that identifies patients with evacuation disorders that you could then just send to physical therapy, as opposed to having to go through the whole rigmarole of sending to a tertiary care center for anal rectal function testing. And then finally, endoscopic-based biomarkers like confocal laser endomicroscopy. I'll say just a quick word about that because I think it's quite interesting. So first, talking about the microbiome, and there are now several studies, probably 4 or 5 different studies, looking at the microbiome. So stool collected from patients with IBS before they go on the low-FODMAP diet. And looking for patterns or patterns which identify responders or non-responders. And now there are 4 or 5 studies which suggest that the microbiome may be leveraged to identify patients more likely to respond to the low-FODMAP diet. Now, here's the problem. All 4 or 5 of those studies identify different features in the microbiome. So there's not, it's right now that we're a long ways from being able to develop a universal theme that could be commercialized, but at least provides proof of concept that the gut microbiome, the stool microbiome, might be leveraged as a biomarker to identify patients more likely to respond to diet-based therapies. And if you think about this, what this is saying is that the microbiome might be leveraged to identify responders to microbiome-based strategies. Okay, remember that diet is at its heart, amongst other things, a microbiome-based strategy. How about metabolomics? Well, there's this study from King's College, a very interesting study that actually looked at stool volatile organic compounds. And the way they did this is they collected stool from patients with IBS before they went into this randomized control trial. And they had the stool in a chamber, and they collect gas that was emitted by the stool. You got to love the fellow that got stuck with this job, right? And then they actually measured volatile organic compounds in that headspace gas emitted from stool. And what they found was that the VOC pattern almost perfectly identified the patients that responded to the low FODMAP diet. And here's the other interesting thing that doesn't get talked about a lot. Part of this study was another arm in which patients received a probiotic supplement or placebo. And the VOC pattern also almost perfectly identified responders to the probiotic strategy. That's important because, again, it reinforces this notion I said to you a moment ago, which is that some of these strategies may be broadly applicable, not just to diet, but to other microbiome-based strategies. This is a study that we published, a post hoc analysis that sort of presents a different way to think about biomarkers. So you may have heard of a condition called sucrase isomaltase deficiency, SID. Sucrase isomaltase is a very important disaccharidase that's responsible for breaking down sucrose into its constituent monosaccharides, glucose and fructose. If you're missing the enzyme, or if the enzyme is not functional, you can't break down sucrose, and it behaves just like lactose in patients with lactase deficiency. So one hypothesis we had after we completed our US randomized controlled trial evaluating the low FODMAP diet in patients with IBS, in which we found that around 50% of patients got better with low FODMAP diet, was one question we asked was, why is it that the 50% that have clear food-related symptoms don't get better with the low FODMAP diet? What is going on in those patients? And we hypothesized that patients that didn't respond to the low FODMAP diet, because remember the low FODMAP diet does not exclude sucrose, would be enriched for sucrase isomaltase gene variants. So they'd have a higher likelihood of sucrase isomaltase deficiency. And in fact, as you can see on the slide, that's exactly what we found. So in your patients, for example, with meal-related IBS symptoms who don't get better with the low FODMAP diet, something you should think about is sucrase isomaltase deficiency. But you could imagine, again, like as these kinds of tests become more widely available, we can start to tailor our approaches and develop algorithms to develop a more precision-based strategy for our patients with IBS. This is that rectal expulsion device, or RED, that I was telling you about. So the whole idea here is this is an office-based device that you can insert into the rectum during your physical examination, during an office-based visit. And by taking the cap off, it self-inflates. So you don't need like a syringe with water or all the sort of difficulties that go along with doing balloon expulsion testing in the laboratory. Literally, you put it in, you take the cap off, the balloon inflates, they can either pass it or they can't. It's that simple. And what we found was, or what we presented at DDW this year, was a reasonable predictive value in terms of response to physical therapy in patients with an abnormal test. So if you have an abnormal rectal expulsion test, you're around 60–70% likely to get better with physical therapy. So the whole idea here is to be able to provide a means by which to screen for an evacuation disorder in the clinic, so that you can make quick decisions in regards to interventions that are effective. So again, a more precision-based strategy for patients with chronic constipation who don't get better with laxative therapy. But by the way, this is just one. There's lots of examples like this for products that are in development that are really simple solutions that could provide ways by which to more quickly get people to the right therapy. All right, and the last thing I'm just going to briefly touch on is confocal laser endomicroscopy. So CLE, for those of you who aren't familiar, is a magnification endoscopy technique, usually probe-based, that allows one to actually gain a view of the epithelium on a cellular level. So during endoscopy, real time, you could actually get a cellular level view of the gut epithelium. And it turns out in some preliminary studies from Germany, some of which is summarized on this slide, that around 2/3 of patients with IBS have identifiable changes in the gut epithelium upon exposure to various food antigens. So by CLE, real time, after application of a solution containing food antigens like cow's milk, wheat, yeast, or soy, these investigators were actually able to identify real-time injury to the small bowel with explosion of epithelial cells, widening of the intraepithelial gaps. And by the way, this was also confirmed in a larger study, around 70% of around 108 patients with IBS who underwent this CLE technique. And it opens the door, again, to endoscopic biomarker-based testing in patients with IBS to make decisions, treatment-based decisions, that is choosing the right treatment for the right patient, in this case, a selected elimination diet based upon CLE findings. So again, I think some of those things were not at-home diagnostics, but I just wanted to show this. There are a lot of companies that are in the business of developing at-home diagnostics, companies that are developing at-home breath tests, including like the Food Marble, really interesting, like almost like a little cassette style device that you can carry around in your pocket and breathe into after a meal, and it measures breath hydrogen levels to give you an idea about whether you're able to break down and absorb those particular carbohydrates. So takeaway points: medications, diet changes, behavioral interventions are evidence-based treatment options for patients with disorders of gut-brain interaction. Integrated care models are superior to traditional GI-centric care models. Digital solutions and platforms may allow integrated care models to scale for a broader audience. And the identification of biomarkers, and I showed you a broad range of different types of ways to develop biomarkers, blood-based, stool-based, devices, et cetera, which will allow subgrouping of patients with conditions like IBS on the basis of abnormal physiology that will enable the evolution of treatment from more empiric strategies where we are now to more precision-based strategies, which hopefully is where we're going. So I think I'll stop there. I would point out that we have this course for GI dietitians that we do every year in Ann Arbor. And this year it's from September 21st to 23rd. So for example, if you have a dietitian that you'd like to get some specialized training in GI nutrition, this would be a good place to send them. Thank you very much.